Welcome to the MRCPology channel for a quick review and understanding of the topic. Imagine a young adult who presents with slowly progressive hand weakness, wasting of the small muscles of the hand, and a strange sensory complaint. They keep burning their fingers or shoulders because they cannot feel pain and temperature properly, but their vibration sense and joint position sense are still preserved. That pattern should immediately make you think about a central cord process, and one of the classic MRCP diagnoses is syringomyelia, especially when it is associated with Chiari malformation. Syringomyelia means there is a fluid-filled cavity inside the spinal cord. This cavity is called a syrinx. The important point is that the syrinx is not just an incidental space filled with fluid. As it expands, it damages the central gray matter and then the surrounding white matter tracts. So the symptoms are produced by anatomy. Once you understand where the syrinx starts and which structures it reaches first, the clinical picture becomes very logical. A common association is Chiari I malformation. In Chiari I malformation, the cerebellar tonsils are displaced downward through the foramen magnum. In simple words, the bottom part of the cerebellum crowds the opening between the skull and the upper cervical spinal canal. That space is normally important for the free pulsatile movement of cerebrospinal fluid between the cranial and spinal compartments. When the tonsils sit too low, they can obstruct or disturb that flow. So the key link is this: Chiari malformation disturbs cerebrospinal fluid flow at the foramen magnum. Abnormal pressure waves are transmitted around the upper cervical cord. Fluid is driven into or within the spinal cord, and over time, a syrinx forms and enlarges. In the first image, the important visual point is that you can see a cavity forming within the spinal cord itself. This is not outside the cord, and it is not simply a meningeal collection. It is an intramedullary cavity. That is why the symptoms are spinal cord symptoms and not simply nerve root symptoms. The cavity begins centrally and then expands outward. This central position explains the classical early finding, dissociated sensory loss. Before going further into symptoms, let us understand the cerebrospinal fluid pathway, because it explains why Chiari malformation can produce a syrinx. Cerebrospinal fluid is produced mainly within the ventricles, especially by the choroid plexus. With each heartbeat, there is a pulsatile movement of cerebrospinal fluid. It flows from the lateral ventricles through the foramina of Monro into the third ventricle, then through the cerebral aqueduct into the fourth ventricle. From the fourth ventricle, it exits through the median aperture, called the foramen of Magendie, and the lateral apertures, called the foramina of Lischka. It then circulates in the subarachnoid space around the brain and spinal cord, and is eventually absorbed through arachnoid granulations and also through lymphatic pathways. Now, the central canal is a small channel in the center of the spinal cord. Embryologically, it is continuous with the fourth ventricle. In adults, it is often tiny, collapsed, or not clearly visible. This is important because students sometimes imagine that the central canal is a major drainage route for cerebrospinal fluid. It is not. The main cerebrospinal fluid circulation is in the ventricles and subarachnoid space. But because the central canal lies in the center of the cord, a syrinx often expands from this central region outward. In Chiari I malformation, the cerebellar tonsils crowd the foramen magnum. The normal pulsation of cerebrospinal fluid is blocked or distorted. Instead of smooth flow around the cord, pressure waves are redirected into the cord. The spoken arrow flow is obstruction of cerebrospinal fluid flow, then abnormal pressure pulsations, then fluid enters or accumulates within the spinal cord, then a syrinx forms, and then the syrinx enlarges. This is why syringomyelia is not just a static anatomical abnormality. It can be slowly progressive. The pressure dynamics continue, the cavity may enlarge, and different neurological structures become involved over time. Now let us connect the pathology to the clinical features. The classic early lesion is in the central cervical cord. The first important structure affected is the anterior white commissure. This is where pain and temperature fibers cross from one side to the other before ascending in the spinothalamic tract. So when a central syrinx damages the anterior white commissure, it interrupts crossing spinothalamic fibers bilaterally. The result is bilateral loss of pain and temperature at the affected dermatomal levels. Because the common location is cervical, this produces the famous cape-like distribution over the shoulders, upper limbs, and upper trunk. The patient may lose pain and temperature sensation in a shawl-like or cape-like pattern. The key exam phrase is dissociated sensory loss. Pain and temperature are lost, but dorsal column modalities are preserved early. So vibration sense, proprioception, and fine touch may remain intact initially. This happens because the dorsal columns are posterior and away from the central canal, so they are not damaged early by a central syrinx. This is a very high-yield MRCP point. A patient with loss of pain and temperature, but preserved vibration and proprioception, should make you think about selective spinothalamic involvement. In syringomyelia, the selective involvement is at the level of the crossing fibers in the anterior white commissure. Now look at the second picture, which shows the spinal cord tracts in cross-section. This diagram helps us understand the order of symptoms. The syrinx begins centrally. Near the center are the crossing pain and temperature fibers, so pain and temperature are affected first. Posteriorly are the dorsal columns, including fasciculus gracilis and fasciculus cuneatus. These carry vibration, proprioception, and fine touch. Because they are posterior, they are spared early. Laterally, we have the corticospinal tracts. These carry upper motor neuron fibers to the limbs. If the syrinx expands laterally, the corticospinal tracts become involved, producing upper motor neuron signs below the lesion. So the clinical pattern is not random. It is a map of the spinal cord being damaged from the center outward. As the syrinx expands into the anterior horn cells, it damages lower motor neurons at the level of the lesion. In a cervical syrinx, this often affects the hands and arms. The patient may develop weakness, wasting, fasciculations, and reduced reflexes in the upper limbs. This is lower motor neuron weakness because the anterior horn cells themselves are being damaged. But if the syrinx expands further into the lateral corticospinal tracts, the patient develops upper motor neuron signs below the level of the lesion, especially in the legs. So the same patient may have lower motor neuron signs in the hands and upper motor neuron signs in the legs. That combination is very important. Think of it this way. Anterior horn cell involvement gives you segmental lower motor neuron signs at the level of the syrinx, while corticospinal tract involvement gives you upper motor neuron signs below the level of the syrinx. So clinically, the patient may have wasting and weakness of the small muscles of the hands, reduced upper limb reflexes at the affected levels, and at the same time spasticity, hyperreflexia, and extensor plantars in the legs. That mixed upper and lower motor neuron pattern should make you localize to the spinal cord. If the syrinx involves the sympathetic fibers around the T1 level, it can produce Horner syndrome. Horner syndrome consists of ptosis, meiosis, and anadrosis. In the context of syringomyelia, Horner syndrome suggests involvement of the lower cervical or upper thoracic sympathetic pathway. If the syrinx extends upward into the medulla, it is called syringobulbia. Bulbar involvement can produce dysphagia, dysarthria, nystagmus, tongue wasting, and other cranial nerve signs. This is clinically important because bulbar symptoms can imply more extensive disease and greater neurological risk. Now let us describe the typical clinical presentation in a more exam-oriented way. Syringomyelia is often slowly progressive. The patient may complain of pain or periesthesia in the neck, shoulders, arms, or hands. They may have sensory loss, but the sensory loss has a special pattern. Pain and temperature are affected more than vibration and joint position sense. They may describe painless burns or injuries because protective pain sensation is impaired. As the cavity expands, they may develop hand weakness and wasting. This happens because of anterior horn cell involvement. They may also develop stiffness or spasticity in the legs, gait disturbance, and hyperreflexia because of corticospinal tract involvement. Scoliosis can occur, particularly in younger patients. In advanced disease, autonomic or bladder symptoms may appear. MRCP trap. Do not confuse syringomyelia with a peripheral neuropathy just because the patient has hand wasting and sensory symptoms. Peripheral neuropathy usually gives a length-dependent glove and stocking pattern and often affects multiple modalities. Syringomyelia gives a spinal cord pattern, dissociated sensory loss, segmental lower motor neuron signs, and possible upper motor neuron signs below the lesion. Another important trap, do not confuse syringomyelia with a dorsal column disorder. In dorsal column disease, vibration and proprioception are affected early, producing sensory ataxia. In early syringomyelia, dorsal column modalities are relatively spared because the posterior columns are away from the central canal. The key clue is the combination of cape-like loss of pain and temperature with preserved vibration and proprioception, plus hand wasting or weakness. Now let us connect this back to the tract diagram again. In the posterior part of the cord, the fasciculus gracilis lies medially and carries lower limb dorsal column information, while the fasciculus cuneatus lies more laterally and carries upper limb and upper trunk information. These are not the first fibers hit by a central syrinx. That is why proprioception and vibration are preserved early. The lateral spinothalamic tract carries pain and temperature after the fibers have crossed. But in syringomyelia, the early damage is usually not primarily in the lateral spinothalamic tract itself. The early damage is in the crossing spinothalamic fibers in the anterior white commissure. That is why the sensory loss occurs at the level of the lesion and is bilateral. The lateral corticospinal tract is positioned laterally. Once the syrinx grows outwards, it can affect these descending motor fibers. Then you see upper motor neuron signs below the lesion. This is why the legs may become spastic even though the syrinx is in the cervical cord. So if you remember one thing, remember this. Syringomyelia starts centrally, damages crossing pain and temperature fibers first, then expands to anterior horn cells, corticospinal tracts, sympathetic fibers, and eventually dorsal columns or bulbar structures if advanced. Now let us move to investigation. The key test is MRI of the brain and whole spine. We do not just image one short segment if we suspect syringomyelia. We need to define the full extent of the syrinx and look for the underlying cause. The cause may be Chiari malformation, a tumor, post-traumatic scarring, arachnoiditis, tethering, or another obstruction of cerebrospinal fluid flow. The third picture is a sagittal T2-weighted MRI. On a T2-weighted sequence, cerebrospinal fluid appears bright or hyperintense. In this image, the syrinx is seen as a bright fluid-filled cavity within the cervical spinal cord. That is the key radiological idea. On T2, fluid is bright, so a syrinx appears as a high-signal cavity inside the cord. The same MRI can also show features of Chiari malformation, such as low-lying cerebellar tonsils crowding the foramen magnum. This matters because the treatment depends on the cause. If the syrinx is due to Chiari-related obstruction of cerebrospinal fluid flow, the aim is to restore normal flow at the craniovertebral junction. Cine-MRI may also be useful in selected Chiari-associated cases. Cine-MRI assesses cerebrospinal fluid dynamics, so it can help demonstrate abnormal flow or obstruction at the foramen magnum. For MRCP purposes, the first line and most important imaging message remains: MRI, brain, and whole spine is the key investigation. Now let us discuss management. The principle is simple. Treat the cause, not just the cavity. The syrinx is the consequence of disturbed cerebrospinal fluid dynamics or another structural problem. So simply draining the cavity without correcting the underlying cause may not solve the problem and may carry risk. In Chiari-related syringomyelia, treatment is usually posterior fossa decompression when clinically indicated. The purpose is to create more space at the foramen magnum, restore cerebrospinal fluid flow, reduce abnormal pressure waves, and allow the syrinx to shrink or collapse over time. If the cause is a tumor, then management is directed toward tumor treatment, often surgical resection depending on the type and location. If the cause is arachnoid scarring, adhesiolysis may be considered in selected cases. If tethering is the underlying mechanism, untethering may be appropriate. The exact management depends on the cause, anatomy, symptoms, and neurosurgical assessment. Syrinx shunting or direct drainage is generally reserved for selected or refractory cases. The reason is that recurrence is possible, and direct intervention in the spinal cord carries risk of neurological injury. So the exam principle is: correct the cerebrospinal fluid obstruction or underlying lesion whenever possible. Now let us bring the whole topic together in one clinical sequence. A central cervical syrinx begins around the central canal. It first damages the crossing spinothalamic fibers in the anterior white commissure, causing bilateral loss of pain and temperature in a cape-like distribution. The dorsal columns are spared early, so vibration and proprioception remain intact. With expansion, anterior horn cells are damaged, causing lower motor neuron weakness, wasting, fasciculations, and reduced reflexes in the hands and arms. Further lateral expansion damages the corticospinal tracts, causing upper motor neuron signs below the lesion, especially in the legs. If sympathetic fibers are involved around T1, Horner syndrome can occur. If the process extends into the brainstem, syringobulbia may produce bulbar features such as dysphagia, dysarthria, nystagmus, and tongue wasting. MRCP trap. The sensory level is not always a neat single line. Because the lesion affects crossing fibers and expands anatomically, the clinical findings can be patchy or segmental. But the high-yield pattern remains dissociated sensory loss, especially loss of pain and temperature with preserved dorsal column function early. Do not confuse this with subacute combined degeneration, where dorsal column and corticospinal tract involvement produce loss of proprioception, vibration, sensory ataxia, and upper motor neuron signs. In syringomyelia, the early signature is pain and temperature loss due to anterior white commissure involvement. Do not confuse this with motor neuron disease either. Motor neuron disease can give mixed upper and lower motor neuron signs, but it does not produce a clear dissociated sensory loss. Sensory findings strongly suggest an alternative diagnosis, and syringomyelia is one of the important spinal cord causes. Do not confuse this with multiple sclerosis purely because there are spinal cord symptoms. Multiple sclerosis may cause sensory and motor deficits, but a fluid-filled intramedullary cavity on MRI points towards syringomyelia, and the association with Chiari malformation is a major clue. So, when you see a clinical stem with a young or middle-aged patient, progressive hand wasting, loss of pain and temperature over the shoulders and arms, preserved vibration sense, and possibly spastic legs, think syringomyelia. If there are headaches, neck pain, cerebellar features, or imaging evidence of low-lying cerebellar tonsils, think of Chiari I malformation as the underlying cause. The most important investigation is MRI brain and whole spine. The most important management principle is to treat the underlying cause and restore cerebrospinal fluid flow where appropriate. Quick recall. A patient has wasting of the small muscles of both hands, reduced upper limb reflexes, spastic legs, and bilateral loss of pain and temperature over the shoulders, but preserved vibration sense. Where is the lesion and which fibers are affected first?